Good evening, everyone, and a very warm welcome to today's Young Turks Journal Club of the Indian Fertility Society. So, a especially warm welcome to all the young Turks. And this is a very beautiful program, a brainchild of our president, Dr. Pankaj Talwar, and so beautifully executed by the entire team, Dr. Shweta, Dr. Nisha, and Dr. Neeru Thakral. Unfortunately, Dr. Neeru and Dr. Nisha cannot be joining today because of unforeseen problems in personal issues that they have. So, I would first of all invite all youngsters, encourage your friends who are not IFS members to become members. And I would also like to invite you all for the Fertivision at Ahmedabad. So all those who have not yet registered, please hurry up. Please send in your papers. The last date is 31st October. And I think with that, we should get started. Is Dr. Puneet there? Dr. Puneet is our expert for today's session. And basically, we will have two talks. I will be talking about the ASRM committee opinion on the use of hormonal contraceptives in fertility treatments. And Dr. Japleen will be doing the Journal Club. So, Rahul, is Dr. Puneet there?
No, ma'am.
All right. So allow me to share the screen so that I can introduce Dr. Dr.
Yes, ma'am,
Japleen will be introducing
you can
me today.
share your screen, ma'am.
Right. Just a moment. I'm getting a call from Dr. Puneet. Hello. Yes, Dr. Puneet. Hello. हाँ जी. Yes, you have to register. लिंक ठीक है. सभी ने इसी से ज्वाइन किया है. तो आप रजिस्टर करो, बस नाम भरो और फोन नंबर भरो and you can join. Oh, all right. Can you see my screen?
Yes, ma'am.
But my screen is not moving, Rahul. It is stuck on this page. Japleen, you will have to do the introduction.
Good evening, everyone, and it is an immense pleasure to introduce one of the most brilliant academicians and practitioners that I know, Dr. Lavleen Kaur Sodhi. She's currently the director cum chief consultant at Sodhi's Healthcare Hospital, an alumnus of PGI, past president of Menopause Society, so has held numerous administrative positions as well, and currently the secretary of the Greater Chandigarh chapter of IFS, and a very dear mentor and guide. So welcome, ma'am, and over to you for the your talk.
Thank you so very much. My talk, like I said, is on the use of hormonal contraceptives in fertility treatments, a committee opinion by the ASRM. And this was published in August 2024, this year. So hormonal contraceptives, as we know, they have a lot of non-contraceptive benefits. They are used in so many different situations. And especially we are using it plenty in fertility treatments, including ART. They are being used for menstrual cycle control, synchronization of the oocyte cohort, modification of the hormonal milieu before controlled ovarian stimulation, and also for suppression of ovarian cyst formation. So menstrual cycle control allows for scheduling of an IVF cycle. A lot of people still do batch IVF, and for them it is a boon to be able to control the cycle with the birth control pills, the hormonal contraceptives. And well, yes, we all go out on holidays sometimes, or we have patients traveling from outstation, from overseas, who also need to schedule their IVF cycles as per their visits. So in third-party reproductive cycles, to coordinate the oocyte donor and the recipient, and to reduce the risk of cancellation of cycles due to unintended pregnancy in the donor. But recently, there was a lot of noise regarding reduced pregnancy rates, live birth rates, so a diminution of the results with the use of birth control pills. So let us see what is the evidence and what the committee opinion is about this. So studies have focused on outcomes including oocyte yield, pregnancy rates, and live birth rates. The ESHRE guidelines reinforce that the use of estrogen and progesterone for scheduling is probably acceptable on the basis of safety and efficacy data. So this was 2022 in human reproduction, the ESHRE guidelines, but they said that the use of hormonal contraception for pre-treatment, the evidence is inconsistent. Whereas an important thing is the effect of hormonal contraception on the markers of ovarian reserve, both the antral follicle count and the AMH. These tests, they say, should be interpreted with caution while a woman is on hormonal contraception, and the counseling must be modified. So each aspect of the use of hormonal contraception in IVF and fertility treatments has been taken up as a separate question. So question number one is, does hormonal contraception impact the stimulation yield of an IVF cycle? The evidence is mixed. A prospective randomized study showed that these women require more gonadotrophins. However, there was no adverse effect on the oocyte yield or pregnancy outcome. Another meta-analysis of 4 RCTs also showed that the ongoing pregnancy rate and oocyte yields were similar. However, the duration of treatment and total gonadotrophin dose was significantly higher. So basically, it means that we may use these hormonal contraceptives, but we must be prepared for a little higher dose of gonadotrophin and a total duration of stimulation being a little longer. Also, we must keep in mind the patient age, ovarian reserve, IVF protocol type, and the duration of hormonal contraception also should be kept in mind. The second question was, does the type of hormonal contraception used differentially affect ovarian stimulation? So there are different formulations available in the market. We have uh, the progestins with greater androgenic properties, the estrane and gonane derivative progestins, the Mala D, Mala N, Dualaton L, and the Overall L. So first and second generation progestins mostly use these androgenic progestins, and it was seen that these may bring down the oocyte yield and they may lower the AMH levels also. So the evidence also supports this. This paper, published in 2012 in the Steroids Journal, showed that androgenic hormonal contraception, when used, there was a reduction in the egg yield. Another paper, however, compared the third generation progestin, desogestrel, and drospirenone, the fourth generation. They did not find any difference. So the last word said on this is that there is a lack of consistent evidence to make a recommendation for a formulation of hormonal contraception being less suppressive for patients who undergo COS for ART. So it cannot be said that one formulation is better than the other, but probably we can avoid using the first and second generation OCPs at least. So does pre-treatment with hormonal contraception impact the live birth rate? So we talked about the oocyte yield, but what about the live birth rate in IVF? So this was a retrospective study, a cohort study, and this showed that at least in fresh IVF cycles, there was a reduction in live birth rate when hormonal contraception had been used. And also, even though the frozen embryo transfer results were not reduced, but the cumulative live birth rate did show a reduction, a significant reduction when the hormonal contraception had been used. But the same year, there was this paper in Human Reproduction, which said that if the birth control pill has been used for 12 to 30 days and a 5-day washout period has been given, then it does not affect the clinical pregnancy rate, live birth rate, or cumulative live birth rates. And the Cochrane review of 2017 also suggested that in both GnRH agonist and antagonist cycles, there is no clear evidence of a difference in the pregnancy or live birth rates. In fact, in antagonist cycles, hormonal contraception was associated with a decreased risk of pregnancy loss. So once again, a mixed kind of evidence is available. And what about the impact of other types of hormonal contraception on IVF sexes? This was very interesting because a large population there are a lot of indications for use of LNG IUD these days. So there may be women who have endometriosis or adenomyosis or endometrial hyperplasia, and we may still need to stimulate them for preserving their oocytes or embryos. So in these women who have the LNG IUD inserted, it was seen that total or mature oocyte yield was not affected, blastocyst progression or fertilization rates were not affected, and whenever the embryo transfer was done, the CPR or the cumulative pregnancy rates or the live birth rates were not affected. So also, if we have egg donors who are having the LNG IUD in situ, we may be able to stimulate these donors with no compromise in the results. However, a lower peak estradiol level and a higher FSH dose would be required. So when we are using stimulating these patients, we must keep this in mind and inform them beforehand about the increased cost. There is not enough information about the etonogestrel implant. Then the next question is that does pre-treatment hormonal contraception impact the live birth rate among women in special populations? So the three special populations were studied. Diminished ovarian reserve was the first one, and not enough information is available. Though one particular article, a retrospective analysis, said that poor responder patients pre-treated with hormonal contraception versus natural cycle, in agonist flare cycles, there was no difference in the implantation or pregnancy rates, but there is very little literature available for this. The second category, special category, is the polycystic ovarian syndrome. Here, this particular paper by Pan et al. Found improved implantation and clinical pregnancy rates in subjects using at least 3 months of hormonal contraception. So 3 months of hormonal contraception compared with either non-OCP users or those who had used it for less than 2 months. And they found better implantation and pregnancy rates. And then other papers also showed similar results. And this particular paper, where the effect was studied in women who had PCOS and were on the antagonist cycles, OCPs were given for 21 to 25 days. In fresh ET cycles, however, the clinical pregnancy rates were lower, and so were the live birth rates. In frozen cycles, however, the similar pregnancy rates, but a higher pregnancy loss rate. So these papers suggested that there may be a disadvantage in using the hormonal contraceptive pill in the antagonist cycle, whereas this particular paper said it may be beneficial. So again, mixed evidence. But we must keep in mind that the risk of ovarian hyperstimulation may be reduced in these patients if they, in the PCO patients who have been on the hormonal contraceptive before they start the IVF. With endometriosis, there is existing evidence that women with endometriosis may benefit from pre-treatment hormonal contraception, specifically pertaining to improved pregnancy rates per retrieval. And Ziegler et al. Demonstrated that a 6 to 8 week course of hormonal contraception pre-treatment in women with endometriosis resulted in higher pregnancy rates per retrieval and fresh embryo transfer. This was significant. So there seems to be an advantage in the patients with endometriosis, but more research is required to determine whether this effect is a result of endometrial receptivity, oocyte quality, or some other effects. Then what about ovarian cyst management? Again, there is different mixed evidence whether the ovarian cyst is harmful or not. Some papers have shown that smaller size cysts up to less than 30 may be associated with increased cycle cancellation due to unexpected LH surge, and larger cysts may be associated with poor response to stimulation. Also, some papers have shown that increased gonadotrophin dosing may be required in the presence of ovarian cysts. And if the cyst is present on one side, lesser number of follicles and lesser oocytes would be recovered from that ovary where the cyst is present. So, and most of us practitioners, if we see a cyst which we suspect is functional or it is not there, it has come up in this cycle only, if possible, we try to cancel the cycle and wait till the cyst has gone. So does it make sense to add the birth control pill or hormonal control contraceptive pills to reduce these cysts faster? But the evidence is that it does not hasten the resolution of the cyst, whether you give the hormonal contraception or not. These cysts are likely to resolve in 4 to 6 weeks. So on the basis of this available information, the committee recommended that hormonal contraception should not be started to hasten the resolution of ovarian cysts, but can be protective against the development of new ovarian cysts. So if there are some women who will repeatedly keep forming new cysts, every month when you see them in the baseline ultrasound, you'll find a new cyst. The previous one may have resolved and a new one will come up. So in this kind of a scenario, to prevent new cysts from coming up, you can use the hormonal contraception. So the next question is, can hormonal contraception be used to aid in the evaluation of uterine cavity before fertility treatments? So for hysteroscopy is very, very commonly used to evaluate the uterus in the fertility patients before fertility treatments. And hysteroscopy is ideally performed when the endometrial lining is relatively thin, usually in the early follicular phase. And if a woman has irregular cycles or she has prolonged menstrual bleeding, then it may be difficult to do it. So these patients would benefit by being put on hormonal contraception at the beginning of the cycle, and then the hysteroscopy can be easily scheduled. How does hormonal contraception affect ovarian reserve markers before initiating an IVF cycle? So if you want to look at the reserve before starting the IVF cycle, you have to be sure that the patient has not been on the hormonal contraception, because both AMH and AFC may be reduced as much as 30%. And once the woman has been on, so this 30% is seen after about 6 months of use of the hormonal contraception. And when it is stopped, this AFC count was seen to start reversing. The reduced AFC count would start recovering within 1 month, but complete recovery may take up to 6 months. So it is suggested that before the ovarian reserve is assessed in these patients, the woman should be off the hormonal contraception for at least 2 to 3 months for both AMH and AFC. Only then you will get the actual true reading. So what should providers be aware of before using hormonal contraception in fertility patients? The usual things, the advanced age, smoking status, history of migraine with aura, increased risk of venous thromboembolic events, and cardiovascular disease. So do not forget these contraindications if you are going to put the patient on the hormonal contraceptives. Though it is thought that just 1 to 2 weeks may not really be helpful, and whatever risk would come with 1 to 2 weeks of use would be lesser than the risk that would come from pregnancy per se. And what are the alternatives? Alternative is the progesterone-only pill. The use of the POP does not increase the risk of ischemic stroke in patients with menstrual migraines and may be an acceptable alternative. But then it is also not all safe, because slightly increased risk of cardiovascular events was seen in women with hypertension, and you cannot use them in women with breast cancer. Also, the incidence of irregular bleeding and cyst formation is higher. To summarize quickly, Hormonal contraception pre-treatment can be used for scheduling IVF treatment. So probably 12 to 25 days of treatment and 5 days of wash-off is allowed. There are inconsistent data that pre-treatment with hormonal contraception impacts ovarian stimulation, although it may increase the gonadotrophin requirement. There is inconsistent evidence that formulation of hormonal contraception impacts IVF outcomes. The use of hormonal contraception in the setting of PCOS or endometriosis is conflicting. Some evidence in favor of endometriosis is there. PCOS has all mixed evidence, and definitive conclusions cannot be drawn. The use of hormonal contraception for the suppression of ovarian cyst has not been substantiated. Treatment with hormonal contraception can be used before hysteroscopy in the workup of infertility. The use of hormonal contraception may decrease markers of ovarian reserve, and those markers may improve after cessation of hormonal contraception for some patients, especially for those women with low AFC. In fact, they suggested that if after the use of oral contraceptives, the hormonal contraceptive, the AFC is normal, then don't expect it to increase after stopping. But if it has been suppressed, if it is below normal, then you should certainly keep it in mind that it may be fallacious. When the use of hormonal contraception is contraindicated, POPs or the progesterone-only pill may be a suitable alternative. So we may use them in timing of ART cycle, reducing the risk of ovarian cysts at IVF cycle initiation, and optimizing the visualization before hysteroscopy. But we must be careful when checking the ovarian reserve in these women who are on hormonal contraception. Thank you. Any comments, Dr. Puneet? First of all, in fact, I must welcome you.
Thank you. Thank you, Dr. Naveen. It has been wonderful hearing you, and you have very nicely summarized these recommendations and guidelines, which I think are very true in our practice as well, practically if we look at it. The only thing is, the guidelines do say that about endometriosis, yes, it may not benefit, but I think there was an era when we were doing fresh transfers in endometriosis. That time, I think, yes, it was very useful, but because now we have moved to freeze-all long-term down-regulated cycles, the pills may not provide much benefit prior to stimulation. So no, I think very nicely summarized. Thank you so much for that.
So I wish there was a little more information and recommendations for fresh versus frozen, like how does it affect the fresh cycles and frozen cycles, and agonist and antagonist cycles. I think otherwise they are nice guidelines.
Yeah. Very
so
nice.
I'm sorry to be introducing you now. Dr. Puneet Rana Arora is very well known to most of us, I think almost all of us, and she's the founder and director of SIFAR Gurgaon, executive member of the Indian Fertility Society, founder member of Fertility Preservation Society of India, medical advisor to Cancer Survivorship Project CanKids. She is an advisor for Late Effects Committee of Indian Cancer Society, executive member and fertility advisor for TY Can India. She has multiple awards: Bharat Gaurav Award for Excellence in the Field of Reproductive Medicine 2016 and the Asia Pacific Medical Excellence Award 2023. So she has numerous publications. She is also a peer reviewer for the Fertility Science Research and the Journal of Human Reproductive Sciences, Minerva Gynecology, Oncofertility Journal. Very, very impressive, Dr. Puneet, and we are really privileged to have you here with us today. So
Thank you. Thank you.
We will move on to the next speaker, Dr. Japleen Kaur, who will be presenting our journal club today. She is one of our young Turks, one of our most brilliant young Turks, one of the brightest stars in the galaxy of our society, our chapter. So she is an alumnus of AIIMS New Delhi. She has done her fellowship in reproductive endocrinology and infertility from PGI Chandigarh and is a member of the Royal College of Obs and Gynae. She has numerous publications, 23 papers in national and international journals, 8 book chapters. She's a peer reviewer for prominent journals, and she has 15 awards in paper, poster, presentations, and quiz, and also was the Women's Health Researcher, got the Women's Health Researcher Awards 2024 in the junior category. Also
Thank you
semi-finalist
so
in
much.
yoga, in fact. So
Thank you so much.
we are looking forward to hearing you, Japli. I will stop sharing my screen so that you can share yours.
Yes, thank you so much for that kind introduction, ma'am, and thank you once again for this opportunity and guiding me throughout. So I'll just share my screen with your permission.
Yeah.
Are my slides visible, ma'am?
Yes.
Yeah. So good evening, everyone. Welcome, Dr. Puneet. So
Thank you.
a brief outline, I'll just talk about the journal that we've taken this article from, a little bit about the background of the study, why it was done, the aim, methodology, results, discussion, the critical appraisal of this particular study, and if it was able to draw any conclusions and give any recommendations, because that's the ultimate idea of studying. Slides. Okay. Yeah, so we chose this article, Anti-Mullerian hormone, as a diagnostic biomarker for polycystic ovarian syndrome and polycystic ovarian morphology, a systematic review and meta-analysis conducted by Kim van der Ham et al. In collaboration between Netherlands and Australia. This was published in Fertility, Sterility in the October 2024 issue, so a recent one. Just a little bit about the journal to know about the impact this article can have. So the journal is a well-known one, Fertility Sterility. It is the official journal of the American Society of Reproductive Medicine with a high impact factor of 6.6, Elsevier being the publishers, and editor-in-chief Kurt Barnhart, based in the USA. So why this study was required? So we know that polycystic ovarian syndrome is a heterogeneous syndrome and has various phenotypes. So the diversity, this kind of diversity makes it identifying it and managing it quite a challenge. Since 2018, the Rotterdam criteria has been universally accepted as the diagnostic criteria for PCOS. So just a revision that any two of the three key features, oligo or anovulation, clinical or biochemical hyperandrogenism, and or the PCOM morphology on ultrasound in adults, after having excluded other relevant disorders. Any two out of these three are currently, we use them as the criteria for PCOS. But the ultrasound discussion of detection of morphology, PCOM morphology has its limitations, like the accuracy, reproducibility of the number of follicles per ovary depend upon the operator and also the machine that has been used. With the new machines of higher frequency, 8 megahertz, the cutoffs have been revised at more than 20, but not everyone is using them. There is an issue between the transabdominal and the transvaginal at detection of these follicles. There is limited use of TVS in adolescents who may not be sexually active. Plus, the adolescent ovaries may have multiple follicles, and then we may end up in overdiagnosing. Follicles also decrease with age, so do we have to have revised cutoffs for different age? We really don't know. So that's why an alternative marker was thought of, that is the anti-Mullerian hormone, a simple blood test. So it was suggested, and it is suitable because it has been seen that women with PCOS do have higher levels of AMH compared with ovulatory women without PCOS. Strong correlations have been observed between follicle number on the ultrasound and the levels in PCOS. Plus the properties of PCOH, like it directly inhibits the recruitment of follicles if it is in excess. It has an inhibitory effect on the FSH hormone-dependent follicle growth. It also inhibits aromatase activity, that is how it increases androgens. So it seems to have a direct role in the pathogenesis as well of the ovulatory dysfunction and the hyperandrogenism of PCOS. So it does seem to be a good candidate for the diagnosis. So the aim of this study was to assess the diagnostic accuracy of AMH for PCOS and for the detection of PCOM. So they divided this into three main questions. to answer the three main questions. The first one being that if AMH is effective in diagnosing the syndrome in an adult woman, is AMH effective in diagnosing the PCOS syndrome in the adolescent? And if AMH is effective in detecting the PCO morphology in adults? So they searched 7 databases, starting from Embase, Medlineal, Web of Science, Cochrane's to PsychoInfo. And the duration of studies, they have included all the studies till 2023. There was a previous meta-analysis which had been done up to 2017. So they included those studies and also the newer studies published between 2017 to 2023. The inclusion criteria was wherever AMH had been used as a predictor for PCOS or PCOM, and the sensitivity specificity values had been calculated and reported. They were published in English, full text was available, and performed in humans. So then the statistical analysis was done, the risk of bias, which is an important part of any systematic review and meta-analysis. It was calculated using the quality assessment diagnostic accuracy studies tool recommended by Cochrane. The random effects model was used to assess the diagnostic accuracy of the test. Teague's funnel plot asymmetry test was used to assess the publication bias, just to rule out that studies with negative reporting or the smaller studies everything had been published, not, or only the positive ones. The sensitivity and subgroup analysis was done as applicable. Then the most important thing is the certainty of evidence for each outcome was determined according to the GRADE guidelines approach. So in the GRADE guidelines, it is not just the diagnostic accuracy, but they also take into consideration the risk, these 5 factors, the risk of bias, the consistency of effect, the imprecision. So the wider confidence intervals affects this, the indirectness or the directness of the results that they have got, and the publication biases, to assess the certainty of the evidence for each outcome, to be able to say that the conclusion can be said or applied with as much certainty. So this is the PRISMA flowchart. Just briefly, the previous studies in the previous review of 2017, they had 26 studies. For the new studies, they evaluated literature. 1644 records were obtained, 975 were screened, and finally, 56 from the new review were included, and total of 82 studies were included for this review. Now coming to the 3 questions that required answering. The first one was AMH as a marker of polycystic ovarian syndrome in adults. So 68 studies were taken for this, had studied this particular phenomena. And in 66 of them, Rotterdam criteria had been used, while 2 had used NIH. When they looked at the risk of bias, there were only 4 studies which had low risk of bias. The rest had moderate to high risk of bias. Now, I couldn't put the whole picture as it was a long one, so I'm just sharing the pooled sensitivity and specificity. The pooled sensitivity of AMH as a biomarker, as a marker for directly diagnosing PCOS was 0.8, and the pooled specificity was 0.87, which are both pretty high, but we can see that there is significant heterogeneity. I-square is the measure of heterogeneity, and when it is more than 75, it is very, very heterogeneous. It should ideally be less than 25 to call it as homogeneous studies. So that's why the GRADE evidence for recommendation, even though we can see that the diagnostic accuracy seems to be high, the sensitivity and specificities of more than 0.8 are good, but yet the GRADE evidence for recommendation was able to say with moderate certainty that AMH levels should not be reliably used as directly diagnostic of PCOS. Like a patient comes, we are suspecting PCOS, we simply do AMH, it is high, and we say that it is PCOS. That's not correct, because there is serious risk of bias and imprecision. We can see that there are wide confidence intervals, and if I had shown you all 68 studies, we could have seen that even clearly. Now coming to the second question, which was AMH as a marker of PCOS in adolescents. 11 studies had studied this parameter, out of which 8 had used the Rotterdam criteria. 2 had low risk of bias. Again, more than 50% studies had moderate to high risk of bias. But in this case, the pooled sensitivity was also low, 0.66 only, and with significant heterogeneity. And the pooled specificity is also relatively less at 0.78. So the recommendation, according to GRADE, was that serum AMH levels should not be used for diagnosis of PCOS in adolescents because the test accuracy itself is limited. And also we can see the high risk of bias. Now, the third question was AMH for detecting PCO morphology in adults on the ultrasound. 7 studies had studied 4. So more than 50% studies had low risk of bias. Only 1 had moderate and 2 had high risk of bias. So we can see all those studies here. And again, the pool sensitivity is good at 0.79. The pool specificity is also relatively good at 0.87. So they said the GRADE evidence was rated as having moderate certainty that AMH levels can be used as a diagnostic marker for detecting PCOM because there was no serious risk of bias, no serious inconsistency, no serious indirectness, and no serious imprecision. Then they also did a subgroup analysis. According to the risk of bias, the results did not change much, even if they excluded the high bias studies. But if they took studies specifically in which PCOM had been excluded in the control group, there was a clear increase in the sensitivity and specificity with a significant p-value. And yes, there was a significant difference between the different assays that had been used, and ELISA having the greatest sensitivity and specificity. But although we know that AMH varies with age and BMI, but even in the studies, if they had not matched or not reported, even after omitting them, the results did not change much. So what about the previous meta-analysis that they, in the previous meta-analysis, they had seen mainly on the role of AMH as a diagnostic marker for PCOS, but not necessarily concentrated on PCOM. So a review conducted in 2013 by Stamtina Iliodromoty, they had studied 10 studies, and in which they had also given a good sensitivity specificity of 79 to 82%. And in this one review, they had given an approximate cutoff value of AMH at 4.7. Another review which had been conducted in 2019 had still recommended, till then it had recommended that AMH levels should not yet be used as alternative for the detection of PCOM or a single test for diagnosis of PCOS. And they said that we still need to wait for improved standardization of assays and established cutoff levels or thresholds based on large-scale validation in populations and different age and ethnicities. Till then, we should really not be using it. So this review has changed that. And regarding the threshold cutoff, which was missing from this current review, so what they found was that there was significant heterogeneity in the studies, and AMH levels are expected to vary with age, BMI, use of hormonal contraceptives, and the different types of AMH assays. And in the various studies that they had seen, the AMH cutoffs had been reported from as small as 0.8 to as high as 10 in the different age categories. Only one review, as I showed earlier, had given a cutoff of 4.7 as a threshold for PCO diagnosis. So as of now, even in the international guidelines and according to this review, they could not suggest a single cutoff of AMH. And what the authors have recommended is that the hospitals and laboratories should determine their population-based and age-specific cutoffs with their own assays till an ideal standard is decided. Now, this review was quite comprehensive if we look at its trends, and it included all the studies. And they discussed 2 outcomes in detail, the role of AMH for PCOS and as an indicator of PCOM. And they had included adolescents as well, whereas not many previous reviews had included them. But it had significant limitations, which the authors have themselves acknowledged, that they had only the English language articles. The studies had significant heterogeneity in terms of the assay types, the thresholds, age, BMI, control group characteristics, and older studies with PCOM being defined by more than 12 follicles per ovary were also included. Then many studies were rated as high or moderate risk of bias. Then subgroup analysis, such as the use of oral contraceptives, which ma'am has very nicely highlighted right now, that it is an important effect on AMH. That was inadequately reported in most studies and could not be studied. And this review could not establish a cutoff value from the various ROC curves calculated in different studies with very different cohorts. So concluding, we can say that AMH is a reasonably sensitive and specific marker for detecting PCO morphology in adults, although it lacks accuracy in adolescents for both M and S. So it can only be used as of now, as it is recommended to be used as an endocrine substitute for ultrasound assessment of PCOM in adults. And it is still unsuitable as a single diagnostic test for a heterogeneous and multi-component diagnosis such as PCOS. So we should still follow the Rotterdam criteria, and at least along with AMH, they should have at least the ovulatory dysfunction or the hyperandrogenism should be demonstrated. And just summarizing, we can see that the 2023 International Evidence-Based Guidelines given by ESHRE. So if anybody has not heard anything at all till now, can just take home these few lines, because this is the crux of the review. The serum AMH could be used for defining PCOM in the adults. These are evidence-based guidelines. And it should only be used in accordance with the algorithm, noting that patients with irregular menstrual cycles and hyperandrogenism, if they already have these 2 out of the 3 Rotterdam, then they don't even need the AMH level for the PCOS diagnosis. And serum AMH should not be used as a single test for PCOS. It should not be used in adolescents as of now. And either AMH or ultrasound may be used to define the third criteria of Rotterdam, that is PCOM. Both may not be required. And the factors influencing must be kept in mind, like the age, BMI, the hormonal contraception, and ovarian surgeries. So preferably the laboratories should be using their population and assay-specific cutoffs. Future directions, so we can see that what we really need to develop is actually a universal AMH assay which can be used worldwide, or at least the agreed on international standards need to be developed. And it would be preferable, it may increase the diagnostic power if we have more studies with cutoff value of more than 20 follicles using the newer ultrasound probes with higher frequency. Thank you.
That was really nice, Japleen. And
Thank you,
Dr. Puneet, over to you for your expert comments.
Thank you so much, Japleen. It was very nicely presented. And I think I'm impressed with the way you methodologically very kind of in a very sequential way, you explained how to present a good journal article. So well done. Congratulations for that.
Thank you. Thank you so much, ma'am.
I think, you've given very nice take-home messages. And I think just I would say, I'm speaking from my experience, obviously, which is level 5 evidence, is that I do agree that before this article came, we were kind of relying more on ultrasound as a criteria for PCOS, because AMH, like you said rightly, the conclusion that still it needs to be standardized. There are a lot of different values we get if we do from different labs. So I think in ultrasound also there's a limitation. It has to be done rightly. Not everybody does it rightly. And if there is a multicystic pattern of ovaries, they're often written as polycystic. So it's very important that the stromal content of the ovaries has to be kept in mind when reporting in the kind of ultrasound as polycystic ovaries. So both have their own limitation. But yes, in a setup where we don't have a standardization of AMH, where we really need to have good ultrasound assessments, I think we both can take into consideration. But I agree that ultrasound still remains an important parameter to diagnose polycystic ovaries rather than AMH. So well done. Thank you for that.
Thank you so much, ma'am.
Basically, the polycystic ovarian syndrome is a very, very heterogeneous disease, a syndrome, basically. and each patient, each woman may present differently. So I don't think AMH will be able to make that single test for diagnosing PCOS. But yes, if it can replace, or it can be another mode of labeling or giving a definition of PCOM, the PCO morphology, I think that itself will be a big achievement. And it has to
Yes.
be actually as per age also. Yeah, as per age,
Yeah.
as per BMI. Because so often we see, those women, we know that they are polycystic ovaries they would have, but they've come later in their reproductive age, so they do not have that many antral follicles. But we
Right.
don't have that cutoff at which age, how much should be the antral follicle number. So these kind of cutoffs, I guess, another few years we should be able to have the right methodology for SA. One of somebody is asked which is the best test, but I don't think we can, at this point of time, we can say which is the best test. We used to say AMH can be done any time in the cycle, but now I think we know it's better done in the early follicular phase.
Yes,
And
ma'am.
we'll
It
have to
shows
have different
variation.
cutoffs for different age groups as well, and BMI related as well. So I think this was the only question that was there in the chat box. Which is the best test for AMH? Is it
Yeah,
ELISA?
actually, it's
So
not. Yeah, it's just that the ELISA has shown better specificity and sensitivity compared to the ECLSIS and the automated immunoassays. But it really can't be said again as best, because things are going to vary with your population and your age and BMI and everything.
yeah. So we need big population studies for our own population. And then
Our
in
own population, yeah.
North Indian, South Indian, everybody, I mean, genetically, sometimes I think we are quite different also. So we need regional assays as well, probably.
And we've always seen also that, when we kind of not talk about PCOS, but in general response to stimulation and all, we know that our antral follicular count and our scans are much better than AMH in guiding us as to the dose of stimulation. So I think, yeah, it's important that, our assessment, like a lot of us now do our scans on our own. And I think this is the right practice ahead, way to go ahead, because, you can kind of assess better endocrinologically by scan rather than reading the reports. So I think we'll have hopefully less kind of a bias from ultrasound scans if we do our own ultrasound scans. Yeah.
So I think with that we can close. And I think we had a nice audience. And like I wrote in my message, I really hope it was worth your time being with us. And once again, I congratulate Japleen for presenting the article, the Journal Club, very, very beautifully. And thank you so much, Dr. Puneet, for joining us today and giving your expert comments. It was an absolute pleasure to have you here with us.
It's a pleasure to be here. Thank you so much.
Thank you,
Thanks
Rahul,
a lot for your
support.
guidance, ma'am.
My pleasure.
You were there
And
with me through every step.
Thank you so
right
much.
from choosing to the last slide. Thank you so much, ma'am.
All right. Bye-bye. We
Thank
meet
you,
again
Dr.
after
Puneet.
fourth Friday for the next Journal Club. Bye.
Thank you. Good night.
Good night.